All right, here's a CT scan of the abdomen and pelvis, and in this particular case, we're going to try to find the appendix, and I'll show you the approach that I use to help identify it. So I start off with the rectum. You follow the rectum back. Here we have the sigmoid colon here. We follow the sigmoid colon up and then around, and then we have the left colon. We follow that up to the spleen here. Here we have the splenic flexure. And then we follow this, and then this is going to be our transverse colon. Our transverse colon is going to go up around the liver here, so here's your hepatic flexure, and then you have your right colon. You follow the right colon down, and usually what becomes fairly easily visualized is your ileocecal valve, because you have some invagination of fat in here. And so this is your ileocecal valve. Usually your ileocecal valve is on the medial aspect. In this particular patient, it is in the lateral aspect. The cecum can flip around and be in any orientation. And so I think finding the ileocecal valve is an important first step in identifying the appendix. So then the appendix is always going to arise from the cecum lower than the ileocecal valve, but on the same side as where the ileocecal valve comes in. So in this particular case, here's our ileocecal valve with our terminal ileum coming in right here to the cecum. So we know that the appendix is going to come in somewhere around this side of the cecum, but lower down. And so when we follow this down a little bit lower, and we go down, we know that we're going to be expecting it coming off somewhere around here, and sure enough, here's our appendix that's coming along the right paracolic gutter and heading superiorly. And this is a nice normal appearing appendix. It's got some air within it. It's not particularly thickened. But that's one way to be able to look for the appendix, is you look for the ileocecal valve, and you know that the appendix is going to come off of the cecum more inferiorly and on the same side as the ileocecal valve.
And as I scroll down, we can identify the appendix right by the arrow here. It's arising from the cecum, which is right here, and the appendix is right here. It's a blind ending tubular structure, so we can follow that, and I put arrows on either side of it, so you can see it's this tubular structure right here. It's filled with fluid, and it's blind ending. If I keep scrolling, you can see we lose it. So appendix between the arrows, extending up till here. This is the tip right here, and then it's gone. So blind ending tubular structure arising from the cecum. In this case, we can see that there's periappendiceal stranding. So that's this gray, wispy looking stuff here, which makes the fat look a little bit dirty, as I've mentioned in some of our previous videos. Contrast that with the what we call clean fat, which is dark. There's no stranding. This is stranding, that gray kind of wispy looking stuff. And you can see there's some fluid kind of around the appendix too. So remember, this was appendix, that circular tubular blind ending structure, and that the gray around it is a little bit of fluid, which is another sign of inflammation. So I'm going to go ahead and put an arrow on that. Right there. So that's an example of stranding. One other unique aspect in this case is that this is a retrocecal appendix. So you can see as I'm scrolling back and forth that it arises, the appendix is right here, it's arising from the cecum, but it's coursing posteriorly behind the cecum. This can sometimes make it tricky to identify the appendix. Something that's helpful for me is to look at it on sagittal. And if I go on sagittal, you can see that here's the appendix again. So I'll scroll through once. Let's see if you can see it. And so hopefully you're able to see it, but it's right here. I'm going to put some arrows on the course of the appendix as I scroll one more time. So now as we scroll, we can see the arrows delineating the blind ending tubular structure arising from the cecum, and in this case coursing posterior to the cecum, since this is a retrocecal appendix with a blind ending tip right here. And there's also some surrounding inflammatory stranding, such as right here, what I'm outlining with my cursor. So that's a sign of appendicitis. So on CT, you'll see dilated appendix, which is fluid filled. Sometimes you'll see an appendicolith, which is will often show up as a radiodensity within the lumen. You'll see wall thickening, and you'll see periappendiceal inflammation, which manifests as fat stranding and fluid surrounding the appendix.
Here's an ultrasound that was performed in a patient with right lower quadrant pain, and so there was clinical concern for appendicitis in this patient. An ultrasound is a reasonable choice, especially in a younger patient who you have increased risk of ionizing radiation, and also in patients who are thinner, where there's a higher pretest probability of being able to identify the appendix. What you're looking for is a tubular blind ending structure in the right lower quadrant, and here you can see this tubular structure here that's blind ending. The blind ending portion is important because there are other loops of bowel within the abdomen and pelvis that can sometimes simulate an appendix. In this case here, you can see that the wall is thickened at 4 millimeters. It's supposed to be less than 2 millimeters, and the overall appendix is measuring 12 millimeters. Normally it's around 7 or 7 millimeters or less. And so this has some concerning features for appendicitis. The other thing I wanted to point out as well is if you look at the fat surrounding the appendix, it is quite bright. And so an echogenic fat is a sign of periappendiceal fat being inflamed. And you can see a small amount of fluid as well tracking within the periappendiceal fat. So echogenic fat is a sign of inflammation and something to look out for. Here you can see it in long view. You can see the dilated appendix, and then if you come a little bit more proximally, you can see this echogenic area with some shadowing. This ends up being an appendicolith more proximally within the appendix. Other things that we can look at as well is we can look at vascularity. You can put Doppler on the appendix to see whether whether it's hyperemic, and in this case here it was hyperemic. The other thing that you can do though with ultrasound, which is quite useful, is that because you have the probe right over the patient's area where the presumed appendix is, you can actually push on it and see if there's focal tenderness in this particular area, and so pressing on it can be useful not only from the standpoint of being able to identify the appendix or see whether it's inflamed, whether that's the source of inflammation, but you can also see whether the appendix flattens out. That a normal appendix, when you push on it, the fluid will go back into the cecum and will flatten out, whereas an appendix that's blocked off and has inflammation and is distended, when you press on it, it's not actually going to flatten out. And so in this case here, they're trying to push on the appendix to see if it flattens out, and there is no flattening of the appendix. And this was the area of maximal tenderness as well. So these are kind of the hallmark signs of appendicitis as seen on ultrasound. Here's a CT scan that was performed in a patient with right lower quadrant pain, and this patient received intravenous contrast. As we scroll down here, we can see extensive inflammatory changes involving the right portion of the abdomen. Looking at here's the cecum, and we can see emanating from that the appendix that looks like that's the center of the inflammatory changes. As we go a little further up, we can see what looks like an enhancing area within the appendix, and then as we go more distal within the appendix, we can see that there's these focal collections with gas in them within the right paracolic gutter extending up to the liver, with small foci of gas within here. And then also if we go further up, we can see that there's some free intraperitoneal air here. And so these are all the hallmark signs of ruptured appendicitis. Given the soft tissue enhancement up here, whenever you think about appendicitis, you always have to think about, could there be a malignant cause of the appendicitis? Could there be some cancer that's obstructing the appendix causing appendicitis? But in this case, this was just complicated appendicitis. Here's a CT scan that was performed in a patient who was having back pain, and so there was concern for renal calculi. And I just wanted to point out an incidental finding in this. If we look at the right colon over here and we follow it down, we'll see here is our terminal ileum coming out here, and so we know that the appendix is going to come off of the cecum a little bit lower and on the same side as where the terminal ileum is entering into the colon. And this is our appendix right here, and we can see that there's this calcified structure at the base of the appendix, which ends up being an appendicolith. These are calcified fecaliths, and they can become impacted within the base of the appendix and can eventually predispose the appendix to become dilated and not be able to communicate with the rest of the cecum, and then become an area that can become inflamed and infected. In this particular case here, you can see that there's some gas within the appendix, so that suggests that there is communication between the cecum and the appendix itself, and that there's not inflammation going on, and there's no real periappendiceal inflammatory changes, and the patient wasn't presenting with right lower quadrant pain either, and so this was noted to be an incidental finding in this patient. But it's important to note because these patients do actually have a predisposition to developing acute appendicitis. And so this patient ended up presenting several months later with right lower quadrant pain. And when we scroll down in this particular CT scan, we can see here's our appendicolith, and here the appendix looks a lot more dilated. And now there's some inflammatory changes you can see surrounding the appendix here, and more distally as well. And so this patient ended up having appendicitis. So noting the presence of an appendicolith is important, not only in those cases where it's incidentally noted, but also in those cases where it looks like appendicitis, to make sure that the surgeons know to dig out that appendicolith, or maybe do a more proximal appendectomy to make sure that that appendicolith is removed. Here's a CT that was performed on a patient with umbilical or periumbilical pain. And so the CT of the abdomen pelvis was performed with contrast. The predominant finding is going to be in the right lower quadrant. And if we focus in on here, here's our right colon. It's actually fluid filled, which can be consistent with the diarrheal state. But if we come down lower, here's our terminal ileum coming out right here. And then we come even lower than that. Here's the cecum, and we can see that there's some wall thickening involving the medial aspect of the cecum extending into what ends up becoming the appendix. And so there's this appendiceal mass involving the base of the cecum. If we follow the appendix out more distally, we can see that it really thins out and looks more normal appearing at the very distal most portions. And so that would not be consistent with appendicitis. When you have appendicitis, you usually have something blocking the base of the appendix, and then the distal parts become dilated, and they dilate all the way out. In this particular portion here, we're not seeing dilation in the most distal portion of the appendix, so that wouldn't make sense for that. This ends up being an irregular soft tissue mass, and so this is a patient with appendiceal adenocarcinoma. Now, the drainage pattern for the appendix is important, and here you can see along the drainage pathway of this, there's an abnormal appearing lymph node that looks quite irregular. If we follow the venous drainage back again even more, we can see an even larger appearing implant or lymph node here. And you want to follow that back up to eventually into the portal vein and into the liver and see if there's metastatic disease in there. And there's nothing on this CT scan that suggests that it's involving the liver, although in subsequent CT scans, this patient ended up having metastatic disease to the liver. So this is a case of appendiceal adenocarcinoma. The differential for this would also include appendicitis, but like we said, it's not dilated distally. There's no periappendiceal inflammatory stranding in the fat to suggest that. Another differential would include appendiceal lymphoma, which is rare. Another differential would also include a mucinous neoplasm, although this looks wall thickened and irregular in shape. Usually a mucinous neoplasm of the appendix will just look tubular and fluid filled and maybe have some REM calcification within it. Here's a CT of the abdomen and pelvis that was performed in a patient who had had an oophorectomy for a right ovarian lesion, and they had incidentally noted a tubular dilated structure, and so they did a CT to further evaluate this. Now, if we look at the right colon here and we come down, we're going to see the ileocecal valve, and that's useful for being able to determine where the appendix is going to come off. And so here you can see the ileocecal valve right here. There's some fat that's coming around there. and then this is your terminal ileum. And when you come further down on the cecum, that's where you expect the appendix to come out, the same side as where the terminal ileum comes in. And we can see that there's a really thickened appearing appendix that's emanating off of the cecum. The appendix itself is here measuring around, let's put calipers on, about 25 millimeters in diameter. And there's some areas of calcification along the edge of it. The other thing to note as well is that the wall of the appendix is not particularly thickened. This seems to be material inside the appendix that's dilating it up. Now, things that we think about when we think about a distended appendix is we think about appendicitis. Appendicitis is not really supported in this particular case. One, because that's not what the clinical setting was. This patient didn't have right lower quadrant pain and fever. This patient incidentally had a node of some tubular structure that they wanted further evaluated. And there's also no periappendiceal stranding that we see on the CT scan. It's pretty clean, the periappendiceal fat. The other thing to note as well is that there's some peripheral calcifications involving this fluid collection within the appendix. And so this is actually very classic for an appendiceal mucinous neoplasm. These patients are important to pick up on because as the appendix becomes more and more distended with mucinous tumor, these things can actually rupture. And if they rupture, now you have mucinous neoplasm deposits within the peritoneum that can eventually cause peritoneal accumulation of mucin, which is referred to as pseudomyxoma peritonei. So it's important to note these things. And if you see a dilated appendix with or without calcifications, then we really have to raise that question of whether this could be a mucinous neoplasm of the appendix. The calcifications help support that. Mucinous tumors typically have a calcification associated with them, but you can also see calcifications with an appendicolith. So it's important to make sure that these calcifications are sure enough along the edge of the appendix rather than representing an appendicolith. Here's a CT of the abdomen and pelvis performed in a patient who is having right lower quadrant abdominal pain. We can see the bulk of the fluid within the mesentery is in the right lower quadrant, suggesting that this is the source of what's going on with the patient. So just going over the anatomy, here's your ascending colon. You can see the fat right here. Here's your ileum coming in, so this is your ileocecal valve. And then if we come down more inferiorly, we expect the appendix to be coming out of the same side, and we can see there's this dilated tubular structure that's extending out. And you can see at the tip, there's actually a hole within the tip of the appendix right here. So one may think, hey, this is a garden variety appendicitis, it's ruptured, but there is something else to think about, and the clue to that is the fact that there are these calcifications that are along the luminal edge of the appendix, and that's not typical for appendicitis. Usually with appendicitis you may have an appendicolith that may be causing obstruction, but these kind of mural calcifications are atypical for appendicitis. And so the things that we have to think about when we're looking at calcifications involving the appendix is, could this be a mucocele? Any kind of mucinous tumor likes to create calcifications, and the appendix is no exception. So when you see these kind of calcifications involving the mural surface of the appendix in a dilated appendix or a ruptured appendix, we have to think of mucinous tumor involving the appendix, and sure enough, this is what happened in this case. This was a ruptured mucinous tumor of the appendix. Here's a CT of the abdomen and pelvis that was performed in a patient who is having abdominal distension. And you can see here there is a lot of fluid within the peritoneal surfaces of the abdomen and pelvis. Now this is slightly different from peritoneal fluid that you would see in the setting of ascites. This ends up being a mucinous neoplasm. This patient has an appendiceal mucocele that had ruptured, and when they rupture, you end up getting tumor cells deposited within the peritoneum that can produce mucinous tumor, and so this is all mucin that's being generated by these mucinous deposits. Here you can see the partial colectomy that was done I think it was a right hemicolectomy that was done with this patient with a ruptured appendiceal mucocele. And one of the features of this, which is called pseudomyxoma peritnei, is that the fluid that's generated is sticky, is mucinous. It's not like your regular ascites. And so this this fluid can actually have mass effect on the liver. And here you can see the liver looks scalloped in appearance. And so that's fairly typical of pseudomyxoma peritnei. It can almost look like this patient has cirrhosis, with surface nodularity, but things that don't really support that is the portal vein doesn't look particularly dilated, the spleen isn't particularly enlarged, and this history that the patient is given of a mucinous neoplasm of the appendix strongly suggests that this is pseudomyxoma peritnei. Here's a CT scan that was done with intravenous contrast in a patient with abdominal pain, and you can see there's this mass here within the right lower quadrant and associated multiple lymph nodes within the drainage pattern of that mass. Now the mass itself, you can see here is the cecum. We have the terminal ileum coming right here, and so this mass is actually coming from the appendix. You can see it kind of bulge out right here and then just expand the appendix with the soft tissue mass. We can also see this on the coronal image right here. Again, we can see the appendix coming out of the cecum and this mass here with associated lymphadenopathy. This ended up being biopsied and ended up being appendiceal lymphoma, which is a very rare presentation for lymphoma. Here's a patient who got a CT of the abdomen and pelvis and was complaining of right lower quadrant pain. And so one of the things that we look at when we're thinking about right lower quadrant pain is to find the appendix. Here you can see the terminal ileum coming into the right colon. You can see the fat surrounding it, and so inferior to that and medial, you can see here's the appendix coming out, and it looks quite normal here, but as you go more distally in the appendix, you can see that there's inflammatory changes not involving the appendix but adjacent to the appendix. The appendix itself is not particularly thickened, but there is a lot of stranding adjacent to the appendix here, and the stranding is actually associated with a globule of fat right here. This is actually epipleuric appendigitis of the vermiform appendix. Mostly when we think about epipleuric appendigitis, we think about the sigmoid colon or the left colon, but you can actually have epipleuric appendages off of the appendix, and these can become torsed or infarcted and can have inflammatory changes associated with it. This is just like any other epipleuric appendigitis, a self-limiting condition, does not require antibiotics. Here's a CT of the abdomen and pelvis performed with intravenous contrast in a patient who is presenting with right lower quadrant pain. We can see on this image there's a lot of inflammation involving the right lower quadrant. And when we come back to it, here's the cecum right here. We can see that there's this dilated appendix that seems to be the center of the inflammation. But there's a couple other things to note is when we look at the cecal base here and we window it a little tighter, we can see that there's actually soft tissue thickening involving the base of the appendix at the cecum. And so this raises the concern for what could be inflammatory soft tissue, but you also worry about a cecal mass. So looking at this particular case, we can actually see that there are some lymph nodes here within the draining mesentery, and then coming back up to the liver, we can actually see that there's a small hypodense hepatic lesion. This patient ended up having cecal adenocarcinoma with metastases to the liver. Here we can see the same patient. Here you can see that mass within the base of the cecum a little better on the coronal view.